Is Debbie Thomas, and I'm a licensed professional counselor and an internationally certified alcohol and drug counselor, and I have a master's of addiction counseling. And I am passionate about addiction work and helping us navigate um, changes because we all want to help people. And sometimes it's the criteria and the funding sources and all of that that are a challenge. The American Society of Addiction Medicine has put out their fourth edition of the criteria. And right now in the state of Idaho, and those of you that take third party commercial insurances, there's a transition time between are we using the ASAM third edition or the fourth edition? And the answer is yes, depending on the funding source. Some are using one and some are using the other. Um, the other thing I would share with you is that the ASAM criteria is the most widely used and comprehensive set of standards for people to recommend continued care, initial care, transition of care, and it's designed for both individuals with addiction and the co-occurring conditions. So if you have not seen the ASAM criteria, it looks like this. And the purpose is to promote individualized and holistic treatment planning. We could probably spend the next 2 days going through the criteria at a high level, or we could spend an entire day surfacing, but we have 30 minutes, so I am going to fly through this. The ASAM criteria was designed for clinicians and care managers so that we can make the best decisions on admission criteria, who should continue in what level of care, and how they move along the continuum. It also is used to assess the biopsychosocial circumstances to identify that appropriate level of care. And then overall, it defines which services should be available in each level of care. So I kind of already talked about the goals, but the biggest goal for the fourth edition was to update it and standardize. The third edition was done in 2013, and this current edition really looked at the state of what our science is telling us and what practice we've learned should be evidence-based. It also promotes the chronic care model, so that seamless movement up and down along a continuum of care. And as I said, focuses on the client and integrating into a holistic process. And the ultimate goal was to try and simplify and clarify any of the ambiguities from the third edition to the fourth edition. So, major changes from the third edition to the fourth edition is there is a separate treatment planning assessment. It needs to stop that silly movement. It moved away from emphasizing a risk factor and moved into evidence-based screening tools. So you're going to see a lot more screening tools that can be utilized instead of the clinician or case manager admission person trying to guess of just because you've had 3 relapses in your past, what does that mean for the current situation? It also emphasizes the increased access to MAT services. It integrates the integrated care. Early intervention is its own chapter. So they took education and prevention completely out of the continuum of care and moved it over into these are important things, but it's not the continuum of a treatment care model. It eliminates things that were at the level of care 3.3, which were specifically designed for cognitive impairments. And level 1 is no longer a treatment model section like we've been thinking of. Outpatient treatment level 1 is not what level 1 is anymore. Level 1 is now long-term remission modeling and support. So more of recovery coaching, alumni support, that kind of thing. Some more changes is the integration of withdrawal management into the biomedical continuum, and that you don't continue your assessment if you realize that somebody needs acute withdrawal and is in danger. You don't worry about the rest of the dimensions. So there's a much clearer focus on what the medical need of a person is and how you integrate that into co-occurring back into primary care. So I tried to create a really simple grid and borrowed this from lots of other things, including the ASAM manual. But moving from the highest level, which is level 4, this is your inpatient care. And we are talking about medically managed inpatient hospital. Think a hospital. Think I can put in an IV. The person can be in a medical unit, monitored all day long, every moment of the day. Our level 3 has changed a little bit in that level 3.7 is medically managed residential. This is where we're looking at biopsychosocial, the co-occurring aspects. You're needing 24-hour a day RN level of care staffing and an emphasis more on medically managing things. The 3.5 is a clinic, actually 3.7 also you need to have a physician that manages and directs the clinical care of the team. Under 3.5, that clinically managed high intensity residential, you need to have 20 hours of treatment over 7 days of the week. It is needing a medical person involved, but this one is clinically managed by the clinical licensed social workers, et cetera, that are managing what that co-occurring trauma evidence-based work needs to be in addition to the medical, in addition to the addiction work. And then our 3.1 is clinically managed low intensity residential. Some of us would think of that as sober housing, but it's not the housing aspect. It's the fact that you need a minimum of 9 and up to 19 hours a week of clinically managed treatment happening at that residential level. So people live there, they're not stable in their home environments. Our level 2, you will see a few different aspects, and you will see things that are medically managed in an outpatient that might not have been in the past. So 2.1 intensive outpatient, nothing has changed in that level of care. It's the minimum of 9 hours up to 20 hours a week, clinically managed. The high intensity outpatient is 20 hours at a minimum and some much more co-occurring aspects. Idaho does not distinguish that type of a treatment. Some people could think of it as partial hospitalization. Um, but we still are having different funding sources look at that differently. And then the 2.7 medically managed intensive outpatient is something that is, again, medically managed, not looking at clinicians running that. Level 1 is much different than we thought about. Level 1.5 is our traditional outpatient that people would think of as, you come in maybe once or twice a week, an hour with your clinician, and that is what's happening from a 1.5 level. A 1.7 is the medically managed outpatient, a person going in and seeing their prescriber for Subutex or other MAT services. And that 1.0 is the long-term remission monitoring, can be focused on recovery coaches, peer support, alumni support groups, that kind of thing. And then the other thing that ASAM has created in this new criteria is recovery residents. There are using the NAR standards in combination, and there are recovery residents opportunities in ASAM that are another whole day that we could spend on that. So those of you that are clinicians that have been used to looking at the third edition of the ASAM, there are 6 dimensions, and they crosswalk differently into the fourth edition. Our acute intoxication withdrawal is now renamed intoxication, withdrawal, and addiction medicines. So there you are assessing, is the person acutely intoxicated? And if so, what is the danger risk based on substance and the amount of use and the health condition of the person? You're also looking at the withdrawal potentials and if those are life-threatening or not life-threatening. And then you're looking at what addiction medicines the person is on or might be able to be on. Dimension two is still the same. It's the biomedical conditions that are occurring. So does somebody have pancreatitis or an open wound or, needs oxygen for COPD? The third dimension is the psychiatric and cognitive aspects of what is going on with the person. The fourth dimension is no longer readiness to change. Readiness to change is now considered in each dimension. As all of us know, somebody might be really motivated for a medical condition and not so motivated on where they live, or vice versa. So the new dimension four is what is the substance use related risk? That risk can be sharing needles. That risk could be where they're living. That risk could be um, the partner that they're choosing to be with. So you're looking at the substance use related risks that are happening. Dimension five is what we would have used to think of as dimension six. That is the recovery environment and the interactions that the person's having. Do they have a great, stable recovery environment at their work and a supported living budget, but at home it's using people and it's dangerous? And then dimension six is the new dimension. And this dimension is person-centered considerations. And dimension six is also the barriers to what care would look like. Think social determinants of health. Think patient preferences. I would like a Christian counselor with purple hair. And then what needs to happen for motivational enhancement. So can you look at the risk, look at the substance use environment, and then take into consideration that this person doesn't want to go inpatient because they have a dog and they won't leave the dog in the care of anyone else. So you look at what you can do to validate their preferences along the way. The other thing that is different from the third to the fourth edition is there is a full assessment, excuse me, a full assessment is not needed for placement. Um, we begin a level of care assessment and you stop at the point where you know what the level of care determination is. For example, if you are looking at acute intoxication and open wounds and someone's oxygen level that is in the 80s, you don't really need to worry about what their social environment is. Did they want somebody that's male or female? You just would go, you need acute inpatient care because you're going to die. Um, However, you do need to look at completing that assessment for continued placement, and you would continue that based on, within 24, 48, 72 hours so that you can learn the whole dimensional aspects of the patient. You also have a second assessment that is required under the ASAM criteria. ASAM says you will do a treatment planning assessment over a several days at the beginning of treatment, and that typically that is different clinicians looking at the person from their scope. So you might have the physician that is doing a health and physical and making some recommendations about physical health and blood pressure medicines. You might have a peer recovery coach looking at it from what the stable environment is and a licensed clinician that's looking at the trauma and what needs to happen, evidence-based practice there. It allows you to really determine what the treatment planning needs of the client will be. Back to the admission criteria is no longer arbitrary for things like, oh, they previously failed at outpatient treatment. That's not a criteria. You could have failed for all kinds of different reasons, and it does not take into consideration what is your acute current situation. So the criteria now is looking at what actually is going on for that person. Care is interdisciplinary, delivered by from a place of empathy. That's the individualized aspect. Care is evidence-based instead of funding source-based, and that you inform and share the decisions with that client along the way of why the continuum of care is asking you to be placed in a particular location. Um, Both assessments are multidimensional. Both assessments will have references to things like resistance and looking at how your assessment notes look. And there was a huge chapter on making sure that you are not stigmatizing and blaming the client. For example, resistance can be blamed on the client oftentimes versus I'm resistant to something based on my fear, being labeled something, their boss knowing about a problem, or resistance because I think I can go to the gym and just live a healthy life and I will figure that out. So resistance can be based on maybe a lack of knowledge and understanding. Um, Relapse potential is also clearly described as not a treatment failure. Being through treatment several times literally just means you've been through treatment multiple times, which is no different. Some other chronic care models, such as somebody had diabetes and it's become unstable, or somebody's blood pressure is doing well and something changes in their life or their health condition. So you're not a failure when you have a return of symptoms or a return to use. We've talked a little bit about the dimensional changes. Readiness to change really becomes, does the person need to change? What's their motivation to change? And realizing that that's a very fluid discussion and needs to be incorporated. So when we look at the assessment criteria for making decisions, when I said you don't have to complete all dimensions, for example, dimensions 1, 2, and 3, if you are looking at these, think of these, it's kind of weird, but when I was trained, think of those as the death dimensions. If you are unstable in levels 1, 2, or 3, then that's where a person may die or acutely can die. So you don't really need to go on and explore the other levels of care. Or the other dimensions, excuse me. Dimension 4 is the likelihood of risky substance use behavior. And then I call dimension 6 the reality dimension. So it is self-determination. It's also looking at the barriers of what the client can reality do. If it's a mother with children, or if it's a person with pets, or there's a lot of trauma in the person's life and they need to be looked at in a different way. Um, Things to note anytime you're reading the ASAM criteria now, there is no longer a point 0.5. So when we would think of point 0.5, in the past, we would think of that as an educational dimension. Now, when you look at anything that has a 7 in it, that is medically managed, and point 0.5 is psychotherapy, so clinically driven. Level 1 is stability and chronic disease management. Psychoeducation, and probably those of you that have begun to get our current managed services in Idaho when they're talking about changes to IOP level of care. Many clinicians and others were calling me going like, what do they mean now? They're talking about the psychoeducational, non-clinical skill building aspect. Well, IOP has always had that multidisciplinary team approach where part of it could be non-clinical as long as it's based in the right criteria. But there has to be a master's level person that is managing the entire treatment component, doing the co-occurring. But the new criteria has really allowed for peer involvement into that level of care. Let's see. We already talked about this, so we'll crank on through. Notes about levels of care. 1.5 is that mild substance use disorder, people in early remission, similar to level 1 in the ASAM 3. We really need to think about 1.7 as MOUD. That is the medically monitored outpatient components of care that had kind of been underutilized or underfunded because people didn't know where to put them into things. Um, how do we integrate the co-occurring capabilities? What ASAM 4 talks about is there is no co-occurring enhanced this, or we're not able to do that. Co-occurring should be in every capable level of care. Programs should be designed with the expectations that clients have co-occurring health issues. There needs to be the ability to manage mild to moderate acuity and instability in co-occurring, whether that's anxiety, depression, bipolar. At least one staff member in the continuum of care should be able to, in that particular level of care, should be able to assess and triage the mental health conditions. That the treatment plan needs to be integrated for co-occurring physical health, mental health, and addiction, and that when you're not able to deliver it, there's a coordination. They say coordination. No longer does it say a referral to, but a coordination with the external mental health providers. Many places were underskilled and would be like, oh, yeah, I just referred you to your doctor and I referred you here. They weren't live, active coordination, and that the programs address co-occurring conditions. So a lot of expectation that was not in ASAM 3. Another way to look at the dimensions or the subdimensions is I summarized all the parts of the level of care assessment. The blue bold ones inform your level of care, and the black ones are for your initial thoughts around treatment planning needs. So dimension 1, you're going to be asking about intoxication and what are the risks. Withdrawal management, what are the risks? And addiction medicines that are needed or were prescribed. And you can see why that's very helpful. Then in dimension 2, you're going to be asking things like, what's the physical health concern? What are the pregnancy related concerns? And those are the level of care dimensions. Oftentimes we'll have like, oh, I can't sleep. I'm on a stimulant. I'm going through meth withdrawal. You don't die and you don't get a level of care over sleep problems. But if sleep is causing you not to be able to breathe, that's a different thing of a physical health risk. In dimension 3, the psychiatric and cognitive conditions, the level of care recommendations, you're looking at active psychiatric concerns, active hallucinations, active suicidal ideation, persistent disabilities, but you're not worried yet in the level of care placement about what cognitive functioning, are you reading at a third grade level versus a 10th grade level? That's not a concern. It would be a concern for treatment planning, but not for level of care. Also, trauma exposures and the related needs or psychiatric histories or cognitive histories are treatment planning needs, not acute level of care decision making. Think triage. Are you bleeding, breathing, going to die? In the substance use related, obviously, we're looking at risky substances and how risky and likely that substance use behavior puts you at risk to die. Dimension 5 in the environment. Can the person function in their current environment, even if it is substandard, even if it's living in a car or on the street? Can they function in the environment? Are they safe in the current environment? Are there any supports in the current environment? Is the discussion about level of care placement. Cultural perceptions and things like that are very, very important for ongoing success in treatment planning. And then in dimension 6, nothing about dimension 6 places you in a particular level of care, but it's very important for treatment planning and whether or not the person will continue to engage in services. Let's see, you're going to see lots of other things in the ASAM 4. Um, but what the level of care assessment does is it says gather enough information so you can match the patient to the level of care that they need, and then assess everything else after that. Stop and don't go any further. The level of care selection will differ based on, client's unique individual needs, but you should then be able to say, as a clinician, why did you say that this person doesn't need, 3.5 and can be managed in 2.7 on an outpatient basis with an MOU prescriber, and that clinical documentation should be there. The treatment planning assessment is the second part. Once they're in a level of care, the ASAM 4 criteria says it needs to be conducted as soon after admission as possible. It does not need to be completed all at once. It might happen over 2 or 3 days in a residential setting, for example. It might be conducted over a couple of sessions if you're in an intensive outpatient, which is different than the current criteria, and it's different than most funding sources know how to navigate. I've had the question of like, well, are they going to start paying us for 2 assessments? Don't know. I'm not trying to outguess what funding sources will do. I'm just trying to share with you what the ASAM criteria are saying is best. Um, you document the client's goals in the treatment planning session and that assessment, and you identify the services that are available to and are supported. And all those universal characteristics are there. Is it trauma and culturally informed, and does it have co-occurring capable aspects to the treatment plan as a whole? What happens when the counselor and the client disagree on placements? In the new ASAM criteria, it talks about that the counselor explains the clinical basis for the recommendation and seeks the patient or the client's feedback on that. The counselor listens very clearly to the client's concerns. Is it childcare? Is it safety? Is it job? And then you explore alternative things. We used to call this like, oh, we're going to substitute IOP for residential because there's not a funding source, or we're going to combine two lower levels of care because the person's not able to do something. You also have to determine if it's imminent danger and risk and try and explain that to the client. And then defer to the client. If they are safe to do so, they get to make the choice. And if they're not safe to do so, then you would need to refer to that higher level of care. And remember all along the way that you're trying to work on motivational interviewing. Whew, so I'm going to stop because that was a bunch. I think I made it. It is 12:35, Shannon.
Perfect timing. Excellent job. Great. We've got a couple minutes for Q&A. No questions in the chat right now, but would love to open it up to our panelists and to go ahead, Chloe. I see you've got a hand up.
I have lots of questions, but I'm going to ask two. Excuse me. So with these changes, they seem big. How do you think that this is going to change treatment moving forward?
Well, I think anybody that's taking Magellan funding on the substance use decide is already seeing um, more awareness of like an IOP level of care, for example, that what exactly many people say, oh, in order to bill for that, I need 3 hours, 3 times a week. They're really funding sources are looking more at what is the capability. Um, I think the other change that we're going to see is confusion over how is a funding source going to line up with these new expectations. There's no funding source that's used to saying, oh, I'm going to pay for 2 types of assessments. And you can hear the language. We think, oh, there should be 2 types of assessments. I run a residential treatment center, and we don't think that way. We think I'm paid for a per diem and I need to take care of the patient. And we are continually every day reassessing, and there's assessment notes in our documentation multiple times through a clinical stay, and you don't have an expectation to be paid for it. So I think all of us are going to be flexible to figure out what is a funding source asking for versus what is the ASAM criteria looking for.
Awesome. And my other question is, do you think with the intake assessment, do you think that's going to lower barriers for getting people into care quicker if there is not enough people to do an assessment? Does that make
I
sense?
don't I don't think so, if I understand your question. The ASAM level of care assessment is going to be interesting because it's going to be done in multiple different locations. It could be there's lots of behavioral health inside of physical medicine now. So do you have a social worker that's like, hey, I've gotten this part of an assessment done. This person is in acute withdrawal and they need to move quickly into care. Are we going to see quicker access with maybe less time to do an assessment? That's a possibility. But I think those are all great questions that I don't have a crystal ball to even guess. If I was going to guess anything, it would be every person on the physical health side, the traditional mental health side, and the substance use side really need to understand this language so that when new information comes out from a commercial insurance or a state Medicaid managed services, that you have a better leap into what they might be describing as their need and be able to advocate for the whole system.
Awesome. Thank you for your insights.
Hmm.
Thanks, Debbie. Thanks, Chloe. Other questions from folks on the call today?
I don't have any questions, but I did just want to say that I feel like this topic specifically can get really confusing for me because I don't deal with a lot of billing or the specifics that are needed for IOP and PHP and what those regulations and different things are changing. And I feel like it was very informative. Like I feel like all the emails I've gotten through my work I didn't really understand, but you like summed it up all really well for me, and now I have a better picture of what's happening, like with Magellan. And what all those requirements are for treatment. And so I really appreciated that clarification.
You're welcome. And I think the other thing I would share is that there's many, many people that are out there trying to do great things and want to help people. And one of my things working for 20 plus years in Idaho and going on 35, well, that probably almost, yeah, 38 as a whole is we end up causing our patients and our clinical staff struggles when we as a whole don't understand. And, if there's clinicians, physicians, anybody that's on here, the more you can stay informed of both sides, become as best as you possibly can at the evidence-based work and the practice that you're doing, but also, stay tuned into what funding sources are asking for, what is happening on your state legislature. Why are state budgets so important? Because it all falls in together. And, when somebody is not funding properly, or, the example of so many providers in Idaho when we expanded Medicaid said, oh, it'll be a great thing. We can put PHP in the sober houses. That's a great idea. Except for it's always been not able to be done under a funding source. You're not allowed to co-locate services. So we end up seeing clients that start to be helped, and then there's a ricochet back of, nope, you can't do that. So um, I hope this gives you just a curiosity of like, go in there and read. If you go to American Society of Addiction Medicine and just look under their public information, there's enough you can read for days and days without buying the book and without having to invest money into this. So yeah, just keep learning.
Debbie, thank you so much. This was such a great topic and very organized and well thought out, as Caitlin said. These slides are on our website, so if you would like to look at them or reference back to them, you can find them on the overview page for this session, and then we will have the recording posted probably by the end of the day today, so you can see that too. So Debbie, thank you.
You're welcome. I would just say, like, I did not create any of that. Most of it is just redoing and condensing what ASAM is already giving as public knowledge. So yeah, check out that ASAM website.